Vascular malformations, they come in four varieties, but the bottom two are usually incidental findings, and they don't cause any major problems to the patients, not even minor problems. Myself, in my autopsies, and a lot of times, my neuroradiology colleagues will see venous malformations as an incidental finding in exams done for other reasons. But the top two, AVMs, arteriovenous malformations, and cavernous angiomas are clinically significant. AVMs are the most common type of malformation. So we are talking about arterial and venous type of blood vessels joining directly without any capillary bed in between. Therefore, you have hybrid vascular channels, part of which are of arterial, and the other part will be venous nature. So maybe we can see the next picture and see, this is a very exaggerated, huge AVM, but you can see the cross section and of a lot of vascular channels. A lot of times these have some sort of a connection to the surface of the brain as well. Microscopically, in the next picture, we will see that the one with the lumen identified with an asterisk has very thick wall in some areas on the right side, yeah, and that is arterial. And if you do a special stain, you will see internal elastic lamina, which is an arterial feature. Whereas right after that, it gets very thin, and then it gets thick again. So this is considered basically an arteriovenous fistula in a way. Another feature is note that there is neuroglial brain tissue in between the blood vessels. And in fact, on the left side, we see that this is located in the cerebellum because we see the internal granule layer right there. So these have, of course, high risk of bleeding, and there are all these clinical parameters to evaluate the risks and when to operate and what to do, maybe embolize, and a whole bunch of management decisions. In contrast, cavernous angiomas have very regular walls to their blood vessels, and they're all packed together without much intervening neuroglial tissue. In fact, neurosurgeons describe them as, oh, it came out like a berry. You know, they just pull it out of there and out of the reactive neuroglial tissue around them and submit to us. So these are pretty straightforward lesions, but they're good to know. It's good to know about their nature and their risks.
Thanks for talking about those. So let's just mention real briefly, and we'll show you some pathologic pictures of these, but some of the brain herniation sites that you can get. So we have this illustration here that really shows you some of the possibilities that you can get. Basically, what happens in these situations is you can get either brain swelling, or actually in this picture here, they're showing you some blood, and that shows up. And then the path of least resistance, when you have that extra material there in the skull, is unfortunately to move the brain in certain directions. So that's where you get these herniations happening. So you can get, what we're showing here is this cingulate or subfalcine herniation, where this top of the brain is moving over here. You can get this uncal herniation, which we'll hear about a lot, and we'll talk about in a little bit, where basically part of the temporal lobe is coming down in this direction. The tonsils of the cerebellum can also go in different directions. And then you can get this fungating type of transcalvarial herniation. So let's look at a couple of illustrations here with Dr. Goktin. So this one, I believe, is I think this is a cingulate herniation. Is that right?
Exactly. Note that the symmetry is gone in the brain, and the right side of the picture, that hemisphere, I'm not calling it right hemisphere because I don't know which way it was placed. But the right side is a lot larger compared to the left. And because there seems to be something going on there, there is edema, and in the white matter, there is some tan brown discoloration, probably representing a lesion. And of course, the arrow in the middle indicates a subfalcine herniation of the cingulate gyrus to the other side. Also note that there is a midline shift to the other side. All radiologic findings that you can see in your patients. Let's see the, of course, when the parenchyma swells up, the ventricles are kind of squeezed, and the lateral ventricle on the side of the lesion appears to be like a slit-like appearance compared to the other one because of this. We do not see uncal herniation here, but I think we have a very good picture of that in the upcoming picture.
Yeah, in a few slides, but I think the next one we have is, so yeah, this is, here we go.
Isn't that impressive? Look at the midline shift to the left, cingulate gyrus or subfalcine herniation to the left, and the transtentorial herniation or the uncus herniation, uncinate herniation at the bottom on the right side. So yeah, there will be quite a few clinical findings that this transtentorial herniation will result in.
Yeah, and
remember that there is the tentorium there, and in the middle, in that what we see as an empty space now used to be the brainstem. So I think in the next slide, we have those summarized. So, okay, what is happening is this medial temporal lobe herniates from the edge of the tentorium between the tentorium and the brainstem down into the posterior fossa. In the process, it compresses the third nerve and the posterior cerebral artery, and therefore people tend to get third nerve palsies and infarcts in the posterior cerebral artery territory. Why hemorrhagic infarction? Well, good question. We just discussed that. Because the herniation may not be static. Let's say there was edema. It will just retract and open up some, allow some circulation to go into the previously infarcted region and can turn it into hemorrhagic infarct now. Because the brainstem is squeezed in that limited space anyway, it tends to show that anteroposterior elongation, kind of a fusiform shape. And of course, when it is pushed to the other side from the herniation side, due to the herniating uncus, then all these penetrating small blood vessels will stretch and tear and result in multiple parenchymal hemorrhages, especially in the pons, called Duret hemorrhages. So these are different from the hypertensive hemorrhage. Hypertensive hemorrhage is usually one big one in the center of the pons and boom, that's it. But Duret hemorrhages are small, multiple hemorrhages in the context of a transtentorial herniation. So they're quite different and easy to tell apart.
Yes, before we get into some of the pictures, we should mention one thing called the Kernahan's notch. So here's an MRI of it. You can see some of the brightness on this here, right on the midbrain. What happens there is you have this indentation of the cerebral peduncle, which is what was happening here, why it's bright. And it can be confusing when you see these patients, because what's happening is that we have this increased pressure, and then you get this ipsilateral leg weakness, or this ipsilateral weakness, I'm sorry, that happens from that. So let's go through this again. So someone has a herniation on this side of their body right here, right? So initially you're expecting to see some weakness on the opposite side, on this side. So as this grows, we get this indentation, some damage, and then this actually will squeeze off the midbrain, which then will actually irritate, or well, just squeeze off the cerebral peduncles, and then you get this ipsilateral weakness from that. It's a little bit hard to see from here, but we'll show you a picture in the next slide that will illustrate it nicely for you guys. So here's that picture.
Yes, the arrow indicates the notch, but not the Kernohan's notch, because we are seeing at the tip of the arrow that, that there is an impression resulting from the tentorial edge. And then we see the herniating portion medial to it between the brainstem and that, that impression. So this is the herniating side, and we see the herniation. And we also see the brainstem showing an elongated anterior-posterior direction, elongated configuration because it is squeezed. Now, Kernohan's notch will be on the other side, because when the brainstem is pushed to the other side, there is the other side of the tentorium there, and it will compress on it. So that edge of the tentorium on that other side will result in the Kernohan's notch.
It's something to bring up because it can be very confusing when you see it. So you're expecting to have someone to have weakness on the contralateral side, and then they develop weakness on the ipsilateral side. So if that starts to happen, this is something you should think about in this particular situation.
But on the top left of the slide, you see that there are a lot of these blood clots, and actually the brain parenchyma is fragmented. And we look into the brain parenchyma where there was apparently a huge amount of hemorrhage, which likely resulted in all this.
So these are, I believe, Duret hemorrhages in the pons. Did I pronounce that right?
Well, excuse my French, but probably just as good as I could have done. But yes, Duret hemorrhages, like we discussed, multiple, smaller, not one big one in the center, and resulting in from the stretching of the penetrating capillaries, blood vessels, due to the pushing of the brainstem to the other side, to one side or another.
Okay, and I think we have one last image to show everyone. Here we go.
That's also a very impressive one. Now we're talking about another type of herniation. This is called cerebellar tonsillar herniation. Usually occurs in the posterior fossa space-occupying lesions, mostly tumors. And what is happening is the cerebellar tonsils are trying to go into the foramen magnum downwards, following the medulla and brainstem. One scenario that I commonly see this is a clinical scenario is at ACH. Pediatric cases, you know, the kid has been having some nausea, not feeling well, and, you know, maybe some visual problems, headaches, and they go from doctor to doctor, and eventually somebody decides to examine the fundic examination and find that papilledema, or decides to take a, you know, head CT, and this huge tumor is sitting in the cerebellum, like a medulloblastoma. And of course, you know, if that doesn't happen, the child eventually will decompensate and become obtunded and come to the ER, and there a posterior fossa tumor will be identified, resulting in this. So that's a very dramatic example of a clinical pathologic finding. And of course, compression of the brainstem interfering with cardiorespiratory centers is not a good thing. And these are deadly situations.
Yeah, all of these compression scenarios that we're talking about do bring out a lot of fear in physicians, because they can easily be very fatal. All right, I do believe that's the end of our talk today. We will see you on the flip side, everyone. Thanks for tuning in with us.
All right, thank you, everyone. Good luck with your studies, and please don't hesitate to contact us. whenever you have some questions or need clarification on any of this.
All right. See you guys.
See you.